afternoon, or good morning for some, depending on where you're joining us from. My name is Iftamit, and I'm one of the board members of the Hospital and the Home Society Australasia. I would like to begin by acknowledging the traditional owners of the lands on which we meet online today. Each of us join from our own homes or workplaces. For me, this is the land of the Wurundjeri people of the Kulin Nation, and I pay my respect to the elders past and present. I also extend the respect to any Aboriginal and Torres Strait Islanders people joining us today. Today, we're very pleased to host this HITH Grand Round webinar focused on treating people who inject drugs while on HITH and showing the success that a multidisciplinary model of care can actually achieve. This session explores how Alfred Hospital in the Home, working closely with their inclusion health team, has developed and implemented a model of care that supports people who inject drugs to safely receive hospital-level care at home. It's a thoughtful and practical example of how multidisciplinary collaboration, flexibility, and harm reduction principle can improve engagement, safety, and outcome for a group of patients who have historically been excluded from HITH services. We're joined today by Dr. Andrew Fuller, Medical Head of Hospital in the Home and Infectious Disease Consultant at Alfred Health, along with Lucy O'Connell, Clinical Nurse Manager with Alfred Hospital in the Home. They'll be sharing their experience designing, delivering this model, including the challenges encountered and outcomes achieved, and the lesson learned along the way. I would like to acknowledge the broader inclusion health team whose work underpins this program. As always, I encourage you to use the chat function throughout the session to share questions, reflections, or comments. These discussions are a big part of what makes the Grand Rounds valuable. I would also like to thank everyone involved in making today's possible. It's our presenters for the generosity in sharing their work, all of you for taking the time to join us, and the members of the HITH Society whose support allows us to continue running these sessions. If you're not yet a member of the HITH Society Australasia, I would encourage you to consider joining. Membership helps support education, research, and collaboration across the HITH community. It is a very easy thing to do. Just pretty much look at the QR code next to me, to my head, and then you can just scan it and become a member today. Finally, just a reminder that the views expressions today are those of our speakers and do not necessarily reflect the official position of the HITH Society Australasia. Any views I share today are my own. With that, let's get started. Over to you, Andrew and Lucy.
Okay, thanks very much, Ifta. I'm Dr. Andrew Fuller. Good afternoon, everyone. I'm Medical Head of Hospital and Home at the Alfred Hospital. I'm with Lucy O'Connell here, Clinical Nurse Manager from the Alfred Hospital and Home program. So today we'll be sharing how our team has successfully delivered intravenous antibiotics to people who inject drugs safely, effectively and compassionately through a partnership between Hospital and the Home and the Inclusion Health program. So as a background, nationally, the proportion of the general population who inject drugs has remained relatively low and stable in recent years at around 0.2% of people having injected in the past year. However, the harms associated with injecting, such as hospital admissions for infections, have been documented as increasing. There was a study published this year at the Alfred Hospital indicates a significant increase in hospital admissions for the last few years for injection-related infections among people who inject drugs. The key findings of this study show that there's, just go back one, that there's a rising incidence, and this has gone up between 2008 and up to 2025, and the hospital separations for injection-related infections has increased 5.7 times during that period. The infections, the common infections include skin and soft tissue infections, bacteremia, osteomyelitis, and infective endocarditis. The bacterial strains, most of them are ordinary staph. We are seeing a rise in MRSA. The burden of disease is really significant, and the associated infections from people who inject drugs have placed a considerable burden on the healthcare system, involving significant healthcare utilisation and cost. And in particular, the specific condition that's most problematic is endocarditis, which is a severe infection without treatment is fatal. And this has been rising, particularly in younger people. Next slide. So We have a lot of challenges and opportunities. Prior to 2021 at our hospital, people who inject drugs were excluded from hospital and home due to concerns about catheter misuse, adherence and staff safety. Since then, we've started taking people, but we have challenges. We have rising cases of endocarditis, spinal infections and osteomyelitis, as I've outlined. And these people need prolonged stays in hospital and they have inequitable care access. The hospital setting can be difficult for them. It can reinforce stigma, can limit autonomy, and it can also trigger patient-initiated early discharge, which is a new word for DARMA, if you like. We have opportunities for intervening while they're in hospital. We can initiate opiate agonist therapy, like methadone and other drugs like that. We can link them with social work and addiction medicine to help them. And our aim is to improve the safety, engagement and outcomes. So when we started this program, we asked, how can we better manage this? And that's when we had the collaboration between Inclusion Health and Hospital and the Home, with a simple but necessarily aim to implement a multidisciplinary harm reduction-based model of care that will allow people who inject drugs to receive intravenous antibiotics outside of the ward environment. So we do have options for treating serious infections. I guess in the past, people would often stay in hospital for 6 weeks having intravenous antibiotics, and that was regarded as the gold standard. I guess we can do 1 or 2 weeks of intravenous and then go to a potent oral antibiotic. So some oral antibiotics such as linezolid, clindamycin, moxifloxacin, those drugs have high oral bioavailability, and that's where oral equals IV. The other option is we can just start off on those drugs, and we've certainly treated patients with MRSA endocarditis just with oral linezolid and they've been cured, and they're for patients who are not wanting to stay. And then I guess the fourth option is long-acting glycopeptides such as eritavancin. And this is expensive. This is about $6,000 a dose, and this is for patients who won't take oral antibiotics. And then the last option is hospital and home. And in fact, you've got the old slide. There is a previous Australian study that showed good outcomes with people who inject drugs on hospital and home. This is from Pauline Dobson's group in Newcastle. They published in 2017. I think they also did a talk at the Hospital Home Conference in 2018, and they had good outcomes with comparing people who inject drugs and people who didn't inject drugs. So we know that it works. Over to you, Lucy.
Thanks, Andrew. So in 2024, the Alfred received funding to create a model of care suitable for this cohort of patients. This centred around collaboration and education, and the Inclusion Health program brought together the infectious diseases specialists, addictions medicine specialists, and addictions nurse practitioner, psychiatry, the social work team, Inclusion Health nurse, the HITH leadership team, and pharmacy. We met weekly via MS Teams to assess the suitability and review care of the patients on the ward. This allowed the team to raise concerns or any perceived barriers and openly resolve any issue. The MDT meeting was really the key forum where each discipline could openly discuss how the patients were progressing, either on the ward or with HITH, and plan for any discharges. Early on, these meetings were also very much about education. HITH hadn't previously worked closely with some of these other disciplines, so there were a lot of discussions around what we could and couldn't provide in the community and what supports from the broader team would allow us to extend our care safely. Having these early conversations about the patient's discharge destination helped us identify whether HITH was the most appropriate option. When it was, it gave both HITH and the patient time to develop a care plan that was realistic and workable for everyone involved. At times, patients were transferred to HITH knowing there was a risk the plan might not succeed, but with a shared goal of giving them the best possible chance to complete treatment. In these situations, we usually had a clear strategy in place for what to do if the patient did disengage from care. The Inclusion Health nurse played a vital role with this cohort. One particular patient who was living in a local SRS that was deemed unsafe for staff to attend initially presented to the HITH daily and arrived on time, but over time began arriving late and becoming difficult to contact. The Inclusion Health nurse, who had already established a relationship with this patient, was instrumental in re-establishing contact through the SRS. Ultimately, it was the patient's decision to cease IV antis and transition to oral antis. And with the support of the SRS, the Inclusion Health nurse and a HITH nurse, we arranged a joint visit to remove the PIC line and provide the patient with their oral antis, along with education on monitoring for any signs and symptoms which would need to be escalated. The Alfred HITH is actually a nurse-led service, so it has been difficult in the past engaging with medical teams once the patients transfer to HITH, unless they remain under the bed card of ID and they're managed by Andrew. Patients that come to us remain admitted under their admitting unit from the ward. So this MDT approach also really allowed for the patients and our nurses to have an escalation point with regards to pain relief management and opioid replacement therapy. So some of the key elements that made this program work really well were education and culture change. The addictions nurse practitioner led targeted sessions for HITH staff based on a series of what-if questions which had been posed by the staff. With her help, over a series of months, we were able to embed harm reduction principles into daily practice, shifting the mindset from risk management to relationship building and support. We had training focusing on the management of the overdoses, the delivery of naloxone, nasal spray, and how to screen for substance use alongside building confidence in staff in asking about drug use. The addictions nurse practitioner has played a pivotal role in shifting staff attitudes towards caring for this patient group. Initially, there were understandable apprehension, particularly around having conversations about substance use, managing perceived risks related to behaviours of concerns, and particularly around the use of the PIC. Our staff had valid concerns around the use of the PIC line if the patient had been using it on discharge for any drug use. So through ongoing education, guidance and support, these concerns were all addressed, which resulted in a care that was more confident, compassionate and patient-centred. The addictions team and the nurses on the infectious diseases ward here are amazing at educating the patients not to use their PIC and explaining the risks associated with that. And we actually don't end up having any patients who attempt to use their PIC when they are on HITH. So building on this, our next step was to support the HITH staff to participate in single-day supernumerary experiences with the addictions team, either at the Alfred or in nearby community centres. And this has allowed our staff to learn directly from experts who regularly work with this cohort. The feedback so far has been extremely positive, and we're planning for all staff to complete the training next year. This ongoing harm reduction education has empowered staff to deliver informed, non-judgmental and inclusive care, and to do so with confidence. So the weekly multidisciplinary meetings assessed each patient's suitability. So to be eligible for Inclusion Health, patients needed to have an invasive infection secondary to their intravenous drug use. The patients needed to consent to the program as it's voluntary and ideally reside within the Alfred catchment. We considered clinical stability, patient engagement, their housing situation, individual preferences, and social and family supports. Social work were able to identify any housing issues prior to discharge and would continue to support the patient while under HITH. A lot of the time, the social work knew the patient's history and had built rapport with them from previous admission. Discussing the patient's family supports were also helpful in figuring out the best place for patients to have their care. HITH care often commenced in the ward treatment room, as this provided a safe and familiar environment for patients. And as confidence and engagement grew, quickly transitioned to either the HITH hub or home, with ongoing support from the Inclusion Health nurse and social work as required. This flexible approach allowed us to tailor care the individual patient needs, build strong rapport and maintain continuity of care. Decisions around HITH versus home-based care were guided by the patient's accommodation type, environmental safety, and available supports. The process prioritised harm minimisation for staff while ensuring informed patient consent. The patients demonstrated sustained engagement with the program, and many were safely supported in their homes rather than the hub. Having the hub as an option for patients' care was another contributing factor in building staff confidence in treating this cohort on HITH. Another benefit of the hub is we do have access to security being present if needed, and that's for any patient on HITH.
Thanks, Lucy. So these are the results over between January 2024 to June 2025. We've had 12 patients with 15 episodes for injection-related infections. That's about one a month. The median age is 45. The type of illicit drug that patients are using, 6 were heroin, 4 were methamphetamine, and 5 patients were using both drugs. All patients received therapy with PICC lines, and we had no catheter-related adverse events. The median length of stay on hospital and home was about 21 days. So they're on for quite a length of time. You can see there the diagnoses on the left. About half were endocarditis, and the rest were spinal infections, osteomyelitis, empyema. And you can see the organisms involved there. 8 were MSSA, we had 1 MRSA, 1 Candida, and 4 streps. And of the 15 episodes, 10 patients received their care in the HITH hub, so they came in each day. And 3 patients, the care commenced in the HITH hub, and then they were transitioned to home treatment. And then 2 patients just received all their care at home. We were happy to go to their patient's home. And the treatment, you can see on the left there, the antibiotics that they had varied. So we've got cefazolin Baxter in 6 with 6 grams of cefazolin, vancomycin CAD in 2 patients, ceftriaxone in 2, flucloxacillin Baxter in 1, vancomycin Baxter in 1, teicoplanin and ceftriaxone, and then ertapenem in 1, and daptomycin, ciprofloxacin, and voriconazole in 1. So that's treatment. During the HITH admission, you can see inclusion health were involved in pretty well everyone. Addiction were involved in 12 people, and psychiatry involved in 7. Keeping in mind there are a lot of psych issues in these patients. And of all the results on the table on the left, that graph, you can see that about half of the patients, 46%, missed or delayed doses. And you can see 27 patients were discharged earlier than planned with transition to oral antibiotics. Usually it was a week or so earlier than planned. But this didn't seem to make any difference because all infections resolved. So that's the take-home message. All infections resolved. There was good positive staff feedback. The staff were very happy with managing these patients, keeping in mind prior to 2021 we didn't manage people who inject drugs. And our staff became quite confident in managing people who used intravenous drugs. And the stigma, and there was reduced stigma and greater understanding of harm reduction strategies. So it was a win-win for both patients and staff.
We just have a case study for you. So we had a 40-year-old female who was transferred from a metro hospital to the Alfred in March 2024 with the MSSA infective endocarditis, requiring mitral and tricuspid valve repair, which she then came on to HITH for IV vancomycin. She had a medical history of amphetamine and heroin use, depression and anxiety, and PTSD. She had quite a complex and vulnerable social history. She was at home with her parents and 3 children. She had suffered some domestic violence, and she had shared custody with her ex-partner and a fractured relationship with her current partner, who wasn't allowed to attend her parents' house. She had also requested her drug history not to be shared with her family. So during her ward admission, the patient had noted that she felt the medical team had talked about her rather than with her during the ward rounds, and she didn't feel like she had been involved in discussions regarding her discharge. This is where the inclusion health was able to initiate, inclusion health nurse, was able to initiate discussions about the HITH program prior to discharge, and it being an option to complete the patient's treatment with us. The inclusion health nurse liaised with both the patient and the HITH team to develop an appropriate plan of care to support her transition home. Inclusion Health were able to arrange Uber transport for the patient to come into our HITH hub, and the HITH team were able to schedule her visit around her school pickup times for her children. She was transferred to HITH in early April for IV antis, with the plan for a shared care between the ward, HITH hub and home. She initially presented to the ward for 2 days, transitioned to HITH for about 4. And then prior to transitioning to home, as that had all gone well, we did a double visit with our NUM and our nurse clinician to the patients of the home that she was living in, do a safety assessment, and it was deemed appropriate to visit her there. She had the remainder of her treatment at her home. Unfortunately, the patient was readmitted to hospital a week post-transfer to HITH with pericardial effusions, which required further surgery, and she had an extended hospital admission where she completed her course of IV antis for the MSSA, infective encarditis. So she completed all that IVs. It's also worth noting she did have another 2 further admissions into the Alfred during 2024, and on both of those occasions she transferred to HITH quite seamlessly, which I think can be attributed to the collaboration between HITH and the Inclusion Health program. So in conclusion, this project demonstrates that HITH can be both a safe and effective for people who inject drugs when supported by a multidisciplinary harm reduction focused model of care. This program was truly driven by strong leadership from the infectious diseases team and the addiction service. Their engagement and advocacy were critical in building trust with patients and enabling successful participation in HITH. The outcomes speak for themselves. There were no line complications, complete infection resolution was achieved, and staff capability and confidence were improved. These results reinforce that inclusion-based care is not only possible, but it works. Rather than excluding people who inject drugs from HITH, we focused on empowering them as active partners in their care, allowing them to recover from serious infections in the comfort and stability of their own homes. And we found that when people are treated with respect, flexibility and dignity, adherence improves and positive outcomes follow. We did have some challenges managing social complexities, maintaining communication between patients and the clinical teams, and building safety with patient autonomy, which required ongoing effort. However, the close collaboration between Inclusion Health and HITH meant these challenges were shared rather than falling on one team alone. This project also challenged us to rethink our assumptions. Instead of thinking, is this patient suitable for HITH? We started asking what would make HITH suitable for this patient. Importantly, as patients become aware that HITH is an option for them, they may be less likely to delay hospital presentation, knowing that they can receive treatment and return home earlier. The Inclusion Health program also increased the leadership awareness of community-based services, strengthening referral pathways and ensuring patients are linked with appropriate ongoing care. Connecting these patients to the right services really helps prevent avoidable admissions, supports early detection of health concerns and reduces delay in seeking care. Looking ahead, we remain supported in managing this cohort of patients. Our next steps include exploring the delivery of treatment in other community services where patients already feel safe and comfortable. Given the often chaotic nature of life for this cohort, reducing barriers to care and meeting patients where they are, where they can significantly improve management and compliance. Overall, this multidisciplinary approach has been extremely beneficial for both patients and staff. We would strongly encourage other services to build and strengthen partnership between hospital and community teams deliver more inclusive, effective care. Thank you.
Thank you.
Thank you so much, Andrew and Lucy, about the fantastic presentation. Just reminding everyone with us today, please, if you're not a member of the HITH Society already, scan the QR code and become a member now. And if you've got any questions, put it in the chat. And I'm going to start with a couple of questions. So you said this whole project started in 2021. What triggered the hospital and your team to make that decision to start exploring it?
Can you hear us still? I think we're unmuted. Is that right? Can you hear us?
Yes.
Okay, great. Well, this program started in 2024, actually. Between 2021 and 2024, we did take a few patients, but this main thing we discussed at the hospital and home meeting in the Sunshine Coast all started in 2024, January 2024. That's when the Inclusion Health program began. And so since then, we've been taking one a month. But in 2021 and 2022 and 2023, we just took one or two patients a year. That's it. But now we're taking them regularly. And we're only able to do that because of the help of everyone else.
Yeah, I think it's just, as we sort of explained, in 2021, probably due to COVID as well, there were more patients that we were trying obviously to see in the community. And it's just given the staff that confidence in continuing to bring these patients on.
Thank you. Is there a reason why we only treat IBDU-related infections? Because as other HITH services, we do see, for example, the heart failure due to methamphetamine use. Have you started thinking about exploring these cohorts?
Well, we do treat heart failure with milrinone and so forth on hospital and the home, but
this program,
this was for infections.
Was focused around
specifically for infections.
Yeah. But we don't exclude those patients. We still treat those patients. It's just shown that with that multidisciplinary team, that the patients probably and the staff get better support. But there may be plans to expand that diseases team and that program funding for that program.
Thank you. We also have a question in regards to the vascular access devices used. Do we always use a PICC line, or do we decide on the device depending on the treatment?
Yes, so for our HITH, any patients that we treat for more than 7 days, it's our preference to do a PICC line, just because of that, instead of having to cannulate them every few days. So for these inclusion health programs, from memory, they all came on with PICCs because their length of treatment was quite lengthy, like it was normally for a week, or longer than a week. But we do take on patients with cannulas as well. And it also depends on the treatment. So if we're treating them with like a Baxter or a CAD, then it has to be a PICC line. We don't connect them to cannulas and send them into the.
Thank you. We all find it quite challenging sometimes with the stuff which are going to the patient's home. How did you manage to change the culture? You did talk a bit about the education provided, but did you find it challenging to some of the staff members to deal with this cohort?
Yes, there was a lot of apprehension, but I think it's really just reminding them that we have our safety assessment for a reason, as long as we're using that correctly, that, we would never send a staff member out into an environment that wasn't going to be appropriate. We can always do double visits and do assessments. We relied heavily on the inclusion health nurse and social work as well, because they really got a lot of that background information for us, and they were very much, and the ward knew really whether it was going to be appropriate for us to go into their home or not. So we did rely on inclusion health nurse and social work. Sometimes they would be like, no, we don't think that's appropriate. So we would trust their opinion.
Did you have a protocol for lost in the community for patients with the PICC line, as well as what was the plan if the patient tampered with the PICC?
Sorry, what was that to the first part, Victor?
Did you have a protocol for lost in the community for patients with a PICC line. So this is always the concern
No,
of...
we didn't worry about whether patients tampered with their PICC lines or not. We didn't worry about it, but mostly they didn't. And in fact, in the ward, we said, if you're going to inject in your vein. But they might have injected in their PICC line, but we didn't really care.
We did, our staff have always...
20% of patients, 20% of those patients I presented actually continue to inject whilst on the program, which is lower than I expected, because they were all injecting in the ward. And so the reason why it's low as 20% is, I think, because of the methadone, all the other supports they're getting.
Yeah, and our staff had always in the past considered, like we've looked at, like I can see Carmen's comment in there about the tamper-proof device. We considered that, or we might like wrap the PICC with some tegaderm to see if they had used it. But our addictions nurse practitioner was amazing with her education and was very much against that because it would be seen as, you know, being judgmental or not
we
the best practice.
Didn't worry about that.
No, the ward just really educated them on just not using the PICC, and if you're going to use your veins, and we were okay.
The aim was to get them to the end of the treatment and cure their infection, which is what we did. Our aim was not to stop them using intravenous drugs because that's very hard. That can take years to get people off heroin and amphetamines. Our aim was to cure the infection.
And we did start having the naloxone, the nasal spray. We brought that in for patients who it was appropriate for. Obviously, depends on what drug they use. But there was always that option. If they had used their PICC and they come into the hospital and we happen to flush, you know, there's some drug left in the line, we have that available and then we can administer that straight away.
Thank you. And what was the process you followed for patients who didn't present daily or missed doses and you weren't able to contact or locate them? i.e., were there welfare checks?
Yes, we would follow our welfare check guideline. So whether that's to next of kin or they don't answer, then going to police. But some of the patients who were in like SRS facilities, we could sometimes contact the people who run that, and they would be able to at least tell us whether they've been seen for the day. And our inclusion health nurse had previously worked in the homeless program for Bolton Clark, so she knew a lot of workers in these different sort of SRSs, or knew some of the areas that would sort of be at during the day. She sort of helped support us locating them at times as well.
Thank you. There is someone asking about clarifying regarding home visits. Is it a single staff visit or a dual staff visit? What are the safety measures?
It depends. So for the case study that we did, the first visit was a double visit just to do the safety assessment, and then because it was deemed appropriate, it was a single visit. So it was all really patient dependent, but we would initially do a double visit and then transition to a single when appropriate. And our safety measures, we have our duress alarms, and then just doing a concise safety assessment for each visit.
If so, I have to go and give another talk, but you can chat with Lucy for a little bit.
Thank you so much, Andrew.
Thanks,
Really
everyone.
appreciate
Thank
it.
you.
So, Lucy, there's still questions coming in.
Yeah.
In which, for Monash, they are letting us know that they've been doing it for a while as well, but they have the rule that the patient have to engage with addiction medicine. Do you also have this rule?
No, with this inclusion health program, we didn't have that rule. They just had to agree to be engaging in the inclusion health program. It definitely helps when they are engaging with addictions team, but it wasn't necessary. And we would normally still be able to refer to addictions if we needed some support, and then they could obviously guide the unit they were under if there was any.
Okay. No, thanks so much, Lucy. Next question, which I have, is in regards to the GP perspective. Did we get the GP of the patient involved, or if the patient didn't have a GP, did we try and find them a GP while they were on the program?
We hadn't engaged with the GPs. just obviously just been because it's HITH and they're an inpatient in the hospital. There were times where I think we've had people under opioid replacement therapy, and we would just we would link in with them around that, because we don't dispense that on our program. But we would always try and link that, especially if they didn't have a GP, the inclusion health nurse would give them, find them a GP and support them before being discharged from HITH.
Mm-hmm. Thank you. We spoke about the inclusion criteria. If we had hard exclusion criteria in this program?
No. They just needed to consent to it. That was it. Yeah.
And something for our listeners, in regards to the program, if they currently are not accepting this patient cohort, what do you recommend that they should be the first steps to get it up and running?
I think discussing with your infectious diseases team, one of the infectious diseases doctors had been doing a PhD around this cohort of patients, so she was quite passionate about it. Your addictions team, and then finding any other sort of so our Ward 7 West is like our addictions, infectious diseases ward, and those nurses are really passionate about these patients and they know them. If there is a ward there, like infectious diseases ward and like NUM that manages this cohort of patients, they're normally really proactive and passionate about providing care for these patients, and especially making it very inclusive. So just sort of tapping into those different wards, medical teams, nurses who manage these patients extremely well. And of course, social work, because social work really plays a big role in a lot of these patients.
Amazing. Thank you so much, Lucy. If there's no further questions, which will give it just one more minute, then we might conclude, but we really appreciate it. Merry Christmas, Happy New Year to everyone. And thank you so much for attending, as well as Lucy and Andrew as well, for presenting.
Thanks, Iftar. Thank you, everyone.
All right. Take care.